And we have a number of very esteemed faculty here today, so I'll just let everybody go ahead and introduce themselves. We could start with you, Dr. MacArthur. It's going to be hard for you to reach that mic.
This is a very big panel. So my name is Heather MacArthur. I'm the clinical director of breast cancer at UT Southwestern in Dallas and the Komen Distinguished Chair of Clinical Breast Cancer Research. Thank you.
Hi, I'm Mary Cianfrocca. I think you met me this morning. For the purposes of this panel, I'm a breast medical oncologist at City of Hope. I'm switching hats again.
Hi, Joyce O'Shaughnessy, breast medical oncologist, Baylor in Dallas, Tex Oncology.
I'm Rachel Lehman, breast medical oncologist at MD Anderson.
Matthew Ellis, my most recent academic job in breast cancer oncology was at the Lester Institute's Breast Center at Baylor College of Medicine. Then I helped AstraZeneca develop drugs for a little bit, and now I'm developing breast cancer tests, so you can talk about that.
Mark Pegram, medical oncology, Stanford University in Palo Alto, California, where I'm medical director of the Clinical Translational Research Unit and associate dean for clinical research quality.
Tanya Gupta, breast medical oncologist and clinical assistant professor at Stanford.
Chirag Shah, outnumbered radiation oncologist and co-director of the breast program at the Cleveland Clinic.
Frank Piccini, radiation oncologist in Michigan.
Tom Buckles, I'm a breast cancer radiation oncologist in San Diego.
Wonderful, welcome. And I would like to invite Dr. Jasmin Hundal to the stage to present the first case. Yay. And really none. We want this to be, enjoyable and no pressure.
No, we want it to be high pressure.
Thank you. So we have a 55-year-old postmenopausal female with a history of stage 4 breast cancer, ER positive, HER2 negative, status post CDK4/6 plus aromatase inhibitor therapy for 2 years, who progressed, and she was then found to have a ESR1 PIK3CA mutation. So the question I would like to answer today is going to be, what would be the next recommended treatment if the patient decided to pursue treatment? So.
We're advancing here. Are we advancing? Yeah. Okay.
All right. So the patient originally presented with a palpable left breast lump discovered during a self-exam. At that time, her performance status was pretty good, ECOG of 1. She was a fairly healthy female with no past medical history, social history, never smoker, no alcohol or illicit drug use that she elicited, and there was also no family history of any type of cancer. A diagnostic mammogram was performed, and the biopsy confirmed the invasive ductal carcinoma, ER positive, HER2 negative. She was staged at 2A at diagnosis with no lymph nodal involvement and no distant metastases. She was initiated with curative intent treatment with lumpectomy followed by radiation therapy. She declined any adjuvant chemotherapy given the early stage as well as the favorable hormone receptor status. And she was initiated adjuvant treatment with tamoxifen for 5 years.
All right, so at the time of the initial diagnosis, I see she was put on tamoxifen. What was her menopause status when she was first diagnosed?
She was premenopausal at that time.
And for the panel, would anybody have been, thinking about an alternative to tamoxifen? Would everybody have used tamoxifen in the adjuvant setting, or would any of one have wanted to do ovarian suppression and AI? She was 52. Now she's 55 at the time of metastatic disease, but she was 50 early 50s at diagnosis.
And still menstruating regularly?
She was in a perimenopause. She was like...
What was her estradiol and FSH?
I don't recall, sorry.
And do you know anything, the grade of the cancer and the strength of the ER-PR or Ki-67?
So the ER-PR was was 95%. PR, I'm not sure, and Ki-67 was like 10%.
And was it grade 1, 2-ish?
Yeah, 1.
Grade 1, grade 1.
And was a genomic assay done, like mammoprint or Oncotype?
That was my question. Did she not get it because she was going to decline adjuvant chemotherapy anyway, in which case it would be useless? Is that why she didn't get an oncotype?
I believe so. Yes.
Well, I think, I can probably respond to most of the panelists here that ovarian function suppression plus an aromatase inhibitor would be a reasonable option as well, as long as she has reasonable bone mineral density, et cetera. And if she could tolerate it, you'll find out real quick, because if they can't tolerate it, it usually happens early, and you could switch back to tamoxifen at that point. That said, for a relatively low-risk node-negative lesion, would an AI afford that much greater efficacy? Not really. Probably not. Tamoxifen is a perfectly good choice as well for these cases.
Also, while the slide said she was going to take tamoxifen for 5 years, you don't, on day one, need to necessarily commit to that. So if she was, say, 51 or 52, by the time she got to a couple years into tamoxifen, she might actually be postmenopausal, and then you could think of an AI without the ovarian suppression. I agree with Mark's comment, though, about tolerability, because particularly if a patient, and I don't mean to imply that she necessarily is this patient, but patients who are kind of averse to the concept of taking adjuvant therapy for long periods of time may be, more tolerant of increasing side effects with increasing levels of therapy. So, it wouldn't have been unreasonable necessarily with a grade 1 tumor to think about a sequential kind of approach, tamoxifen for a few years till she's postmenopausal, and then introduce an AI.
That's a very reasonable option as well. I remember the presentation of the SOFT safety database back in the day, and there was a statistically significant increase in hypertension, depression, statistically significantly increased with OFS plus AI, sexual dysfunction, bone mineral loss. I mean, these are not inconsequential adverse events for AI, and so those do have to be taken into consideration, and they offset some of the efficacy benefit.
There's an online algorithm that takes the soft and the text data, and as you know, they looked at like 7 different variables centrally in that beautiful paper in JCO by Meredith Regan, looking at centrally done ER-PR, Key 67, grade, age, and just splaying out how do the patients do with each of these variables with tamoxifen, LHRH versus LHRH AI. And so they have a online algorithm, because they have it in the paper. They have this algorithm that shows you patients that are very high risk, they need LHRH AI, patients that are lower risk, per this algorithm, they just do fine with tamoxifen, they don't get any additional benefit. So it's online now. You can just, if you just Google OFS benefit algorithm, but it's a Dana-Farber, it's dana-farber.harvard.edu composite risk step, STEPP. So it's very nice to really get a real feel for what the estimate would be around additional benefit with going beyond tamoxifen for endocrine therapy.
Also in soft and text, I'm reminded that the really big benefits are in those patients that are under age 35. And so this patient, at 50, let's say, the benefits are less. And while the hazard ratio may be similar for this case, as is higher risk patients, the absolute benefits are going to be really small, comparing AI, OFS versus TAM, in my opinion.
Great.
I think the bigger question for this patient population that's perimenopausal is not so much about Lupron or ovarian suppression, but it's about the artfulness of medicine, about when you switch them from tamoxifen to an aromatase inhibitor, and Matt mentioned estradiol and FSH, a lot of different data around what's actually helpful, and then of course you give them tamoxifen, and that can do any number of things to menstrual cycles. So I think that's the more challenging question for this specific
I had patients who actually chose ovarian suppression because they were fed up with their menses at 50, and they were having heavy menses, and they said, "Give me that drug because I'm fed up with
DSO,
yeah."
because they
Yeah.
just don't.
So I think every patient's different in this setting where, the endocrine therapy has pros and cons. And the great thing about ovarian suppression, you can always stop it if the patient's not tolerating it. So I think overall, I agree with everything that said it's a situation of sensitively sitting with the patient and going through each of the options and then coming up with the right one for her, knowing it's a relatively low-risk case, although I think you're just telling us you became metastatic. And I'll give you a story about that in a minute, because amongst these so-called low-risk patients, there's some very bad actors that we can't currently diagnose, but I'm writing a paper on the molecular lesions that drive the poor outcome in low-risk patients.
The thing for fellows to, learn in these cases, they're perimenopausal and they may have cessation of menses at that age. That does not equate to biochemical castration. You have to measure the ultra-sensitive serum estradiol to know where you're at, because lack of menses does not mean that the ovaries stop producing estrogen. It just means it's no longer cyclical.
But it can still be measurable, and it can still be in concentrations that are sufficient to activate the estrogen receptor.
You become pregnant. Yeah.
And so,
Well, there are ladies have new husbands in 50 and they do get pregnant, right?
Just as a practical question, who tests FSH in addition to estradiol in the setting to try and make those two?
I too, I get an range of FSH estradiol. I don't know if that helps me, to be honest with you, but it's just fine.
I actually stopped because I didn't find it helpful. I found it confusing more than.
Well, with FSH, you have to think about all points of the same. They must be for it to be informative. But sometimes it's useful because it implies a degree of ovarian failure. The FSH is sort of fogging the ovarian to make estrogen and they're sort of on their way. You did the estrogens in the sort of premenopausal rate and the FSH fledging out. And then likely to be perimenopausal. So, it's good to sit in chat to endocrinologists, when you test stage or other signal in.
I agree. Like I said, Heather, I used to check it as well, the FSH, and then often I would find that if it's discordant there, it didn't really make sense with the high sensitivity estradiol. It's an error count.
Why not act in the album type? Get 50, why not do the test? Because, if she's going to refuse chemo anyway, then there's no reason to have it. Well, I mean, if you went to her and said your score is really high, I really think you should have chemotherapy, she might seriously consider. Okay, well, if you think that's the case, I mean, sometimes you did develop that aesthetic. Some patients are absolute, but they are not going to take chemo.
Yeah, but I see from kind of say something very different here. I want to know that result because, of course, there's issue of, in fact, is that Ki-67 result correct? Is she actually a high-risk patient? You shouldn't get better simply. There's lots of subtlety here, and the more information you have is orthogonal in the more helpful it is, in my opinion, because you're making very difficult calls in this thing to go for minimalistic therapy, and we're about to find out it didn't go very well. So what aspect of this case can we learn from, or did we get wrong? Well, it might be you didn't get the old neuroscience test.
Then lower risk to people with green one, the sentinel was taller, so it's not necessarily that giving you more treatment.
And right, it's not clear. There's bad actors buried amongst the good actors. The therapies we have today could be awfully effective. That means.
Again, as a teaching point, we all love to see the science, and we're all very curious to know a lot of these variables, because we do research and we have a natural instinct and curiosity about such things. But at the end of the day, in the clinic, medically speaking, if you're going to work any diagnostic test, it's not going to change your treatment, that there's no reason to put in tests. And it doesn't have to be oncology, it could be any test. That's a fundamental principle that is taught. That's something. So that was my point for teaching purposes. You're not going to use the information, there's no one to get it. In this case, you make a strong case that maybe you could change your mind and then spare on. It would be very interesting to question about it. But interesting doesn't help you if the patient is absolute. They're not going to take chemo under any circumstance. In that case, I'd be circumspect about spending the thousands of dollars in tests.
All right, so let's put box for 2 years. Follow-up imaging revealed asymptomatic bone metastases. Third bone biopsy was performed, which was significant for metastatic breast cancer. NGS sequencing was
performed on the tissue, revealing an ESR1 PIK3CA mutation.
Which mutation?
Right.
Good question.
Do you have the specific mutations?
I don't, sorry.
No worries. All right. So first of all, were these imaging studies done to work up something else, and we kind of found these asymptomatic bone mets on accident, or what was surrounding the imaging?
Yes, so this was, she went in for abdominal pain and she got a CAT scan of her back and then, of her abdomen, pelvis, and that's when they found some bony lesions and hence the follow-up.
And there was no visceral disease at all? It was just bone mets? Okay. So is everybody doing their next generation sequencing? And I guess let me back up a moment. It also showed estrogen receptor positive and HER2 negative, same as the primary. And grade on that biopsy, also same as the primary? Okay, so are people doing their next generation sequencing in these sorts of patients up front on the initial tissue that you get to confirm metastatic disease? Are you sending liquid biopsies up front? Are you waiting till the second line? How are people's practice with that?
Oh,
sure.
There's a simple
Go for
answer
it.
to that one, because the elazestrant guys were just out the door to the right. ESR1 mutations are not seen in primary breast cancer, less than 1%, and that mutation that they see, E380, whatever it is, Q, is not particularly activating anyway. So most of these are acquired mutations, only present after a period of selective pressure from the aromatase inhibitor, so you have to do it on the metastatic disease, otherwise you'll miss it. The point, in my view, with bone disease, it's tricky. So it's usually a blood-based test with sort of preordained sequencing panel that'll pick up, I think, clinically significant ESR1 mutations most of the time. Is that what you do, Joyce? Your blood test, or would you biopsy her bone?
I would biopsy the bone for diagnosis, but you can't get good NGS on bone, so I would send a liquid biopsy. But if she had liver or something, I could do NGS. Every time I do a biopsy, I try to get enough tissue for NGS, and I send blood as well. So I get blood up front. One could argue you don't have to have it because you don't make a decision on a molecular therapy till after progression on first line. But I mean, this patient, this is bad news, to be, I'd like to, what nasty mutations did this patient have? Because I want to start thinking about trials for this lady. What's going to be the next step? What's his natural history going to look like? So I try to get a feel for the cancer as best I can. So I would send the NGS and blood even up front on these patients.
Can I just make one comment you made, though? It's very important you order EDTA dissolution of bone, not acid formalin, because it's the acid formalin that kills the DNA. So you really have to work with the pathologist so they know how to handle that biopsy and not put it in the wrong tube or the wrong bone dissolution
And then
matrix.
you can get NGS on it.
Then you can, but you have to talk to them about this EDTA buffer, not acid formalin, which is what they would normally do, because they want to get rid of the bone of 24 hours. But if you use the EDTA, it takes 3 or 4 days. But it's worth it, because then you can actually sequence the DNA from the biopsy.
That's very little known. I didn't know that, so thank you. Yeah.
As per my usual, I'll take a slightly contrarian point of view.
That's why I'm sitting next to you.
And that is, you're going to give this patient a CDK4/6 inhibitor and an AI, no matter what your mutational profile is, at first metastasis. It may be nice to know for the future so that, you can be ready for the second line. But the status of ESR1 and PIK3CA can change during the life of a metastasis. So if they're both wild type at first metastasis, when they progress, you're still going to have to resequence them anyway. And you're going to get CDK4/6 anyway, so you don't really need the genomic data, in my opinion, for the first line decision making, and it would not impact the decision. In fact, in Paloma 2, the ESR1 mutation status and PIK3CA mutation status had the same hazard ratio for benefit of PFS in Paloma 2 as the wild type sequences. So I would probably wait and then sequence at the first progression. Now, there's a nice paper from the group at Chicago. What's the company there? Tempest, thank you. I don't want to plug this because it's not commercial, but there's a very nice paper from Tempest published recently, and they looked at tissue versus blood, and they found that they're each complementary. You can pick up some mutations in the tissue that you miss in the circulation and vice versa. So if you really want to maximize everything, if it's feasible and safe, you could do both. But the fraction that you gain is modest, and I'd be perfectly content with circulating tumor DNA like Guardin360, et cetera, at first progression after a CDK4/6 inhibitor.
Why do people choose? Why palbociclib?
This was probably before the ribo data was reported with the survival.
Well, the other thing is, the abemaciclib data were recently reported, and it didn't reach statistical significance for overall survival, but the p-value was 0.06, and the curves were perfectly nicely well separated, same as the ribo data. You could argue that the palbo data look almost the same, but their shortcoming is all the patients that were lost to follow-up. They also had a double-digit frequency of crossover. So that was a contaminated OS data set. All of them are underpowered for the OS endpoint. So you could, if you came from another planet and looked at all 3 OS data sets from each of the CDK4/6 inhibitors, you would probably conclude that they're the same, in my opinion. Failure to reach statistical significance when the survival post-progression is well longer than 2 years requires thousands of patients to have a power of 0.85 or better. There's a nice paper on that topic from Broglio and Berry in the JNCI about 10 years ago.
So can I push you a little bit, Mark, because your arguments are resonating with my resource allocation Canadian point of view. So I agree with everything that you've said so far. So if you weren't doing mutation analysis up front and you were waiting to progression, but a patient progressed after 5-7 months of CDK4/6 inhibitor therapy, is there any role for ESR1 or other mutation testing at that point? Or how would you approach that?
At first progression on CDK4/6, absolutely, because then it's going to define your second-line treatment.
But are you looking for ESR1? Because the elacestrant data, right, shows that if you've had 12 or more months of prior CDK4/6
well, let's talk
inhibitor
about
therapy.
that. What are the hazard ratios? The hazard ratios are almost identical. It's the absolute difference that changes with shorter progression on CDK4/6. Are you not going to use elacestrant in those patients? What else is going to be better? The control arm still did worse.
I mean, I would, but I'm just pushing the point for the, the trainees in the room.
So, since you're from Canada,
Yes.
there's a very interesting company in Canada called Repair. So the relevance is this tumor P53 mutant?
No. No.
Let's assume it is. There's a very well, because that's the point about cases, right? We have a paper coming out in Molecular Cell Therapeutics on a WEE1 homologue called PIK3CA, where there's it's a sort of synthetic lethal patient, synthetic lethal treatment for patients who have a broken G1S checkpoint. That's why they're progressing through CDK4/6 inhibitor. And then if they're P53 mutant, they respond to this WEE1 homologue therapy. And because it's not WEE1 inhibitor, which is toxic, but it's a selective WEE1 homologue regulated by the estrogen receptor, right? And the trial's open in Canada, and the company's Canadian. So you want to look up this PIK3CA target. The paper was accepted yesterday, actually. You sort of give it with a little gentle dose of capecitabine, causing enough DNA damage and repair stress that then the cell with the chemotherapy damage then bumps into M phase with incompletely replicated chromosomes, and then the cell dies. Cool. So the point is there's more mutational possibilities evolving beyond just ESR1 and PIK3CA. The other thing I'd want to know is whether the patient had a HER-2 mutation.
Mm-hmm.
Right? Yeah. Presumably doesn't, but they definitely occur. So there's a bunch of other mutation-driven, options for these patients that are emerging, I'd say. And I'll stop there.
Yeah. Was anyone surprised to see the ESR1 mutation after tamoxifen? Is that something that's commonly seen?
That's a good question.
It's distinctly uncommon after selection pressure from tamoxifen. But, there is about a 1% frequency de novo in primary breast cancer, so this could have been one of those. You don't know. Yeah. It's possible. And there's a small fraction that will convert to mutation following tamoxifen, but it's a real small fraction.
So now if you had this ESR1 mutation up front when you're planning your first-line therapy, she's not been exposed to AI before, but maybe we think AI isn't going to work. Which endocrine partner would you be choosing for your CDK4/6 if you knew they had upfront ESR1 mutation after tamoxifen?
You'd be forced to use fulvestrant, wouldn't you?
Fulvestrant.
Yeah, agreed. And did anybody else want to comment at all about their choice for CDK4/6 inhibitor? It would be interesting to kind of hear what all of you are doing for your
Well, I mean, the thing of it is that NCCN not only considers the efficacy signal, but also the level of evidence for that signal. And that's a very important distinction. So if you're a guideline committee, you're going to focus on the magnitude of the benefit and the level of evidence you have to support that magnitude of benefit. And clearly, ribo wins. So I do use ribo, don't get me wrong. But, from a scientific point of view, you could argue that there's a lot of similarity between the three. That said, level 1 evidence of a survival benefit is the holy grail in solid tumor oncology. There's nothing not to love about that. So I think we all prefer to use ribo still. But if I see a patient that comes in like this one in consultation and they're on a different one, do I switch them to ribo? No way. I tell them that they're getting good care and then it's acceptable because I believe that. Oh, sure. Yeah, but palbo's the best tolerated, arguably, anyway.
And we probably all have many patients that are 6-8 years on palbociclib, and they're doing great, no evidence of disease. So, I mean, we know the drug works, but I agree, ribo first. So if you want to...
Next. Yep. All right, so then the patient complained of more bone pain and fatigue.
Can you just tell the first line?
Oh,
Because
sorry.
the panel mentioned it, but...
Oh, yeah. So then she was initiated palliative intent treatment with palbo and letrozole. Managed side effects were neutropenia and fatigue. She required 1 dose adjustment, and then she had a partial response with a significant reduction in the tumor markers and stabilization of the bone mets for about 2 years. Then she complained of more bone pain and fatigue that prompted restaging CT and bone scan, confirming the disease progression with increased bone activity and new liver metastases at that point. She was still of good performance status of ECOG 1, and she had a good supportive family and was participating in a breast cancer support group. At this point, she wanted to really just focus on quality of life and prolongation of life, and it was interested in treatments with manageable side effects to still maintain an active lifestyle. So what would you recommend as a next recommended treatment if the patient decided to pursue further treatment?
Just a couple questions for you. Actually, first of all, for our radiation oncology colleagues, now she's got painful bone mets, whereas initially they were asymptomatic. So would one of you mind kind of taking us through how you approach painful bone mets, what modality you're using, depending on the site?
Yeah, so, I mean, bone mets are kind of part and parcel of what you do if you're a breast cancer radiation oncologist. I tend to favor less is more. I think particularly given the data that's come out on KERB and BR002. So even in the setting of limited bone metastases, I don't use much SBRT anymore. I think 8 and 1 is a really good regimen, single treatment. You can often simulate them and treat them the next day. Don't delay any systemic therapies, low side effect profiles, limited impact on their bone marrow. I think that works really well, and it's a good thing to do. The only thing is that if you treat the abdomen and pelvis, you may want to pre-medicate them. You can cause side effects. The thing that actually I surprise a lot of my medical oncology colleagues with is, I don't know how many liver mets this patient had, but we do see patients who get pretty bad liver burden and they get pain from capsular pressure. And it's an old technique, but whole liver radiation is beautiful. It's older than I am. It's been studied prospectively by the RTOG starting in the 1970s, and it's like a beautiful palliative approach for liver metastases burden causing pain. So if there's limited disease and there's no symptoms, you don't need to, but it's an often forgotten approach that works really well.
What dose do you use?
So I will say again, the RTOG studied a 7-fraction regimen, 21 gray and 3 fractions, and Laura Dawson is like the world's expert in radiation-induced liver disease. Again, I'm pretty pragmatic. I often give a single fraction, or if I really want to, I'll give 2 fractions, but less is more, and you don't see any issues with obstructive issues, radiation-induced liver disease with those types of doses.
I'm sorry, that's with oligometastatic disease, or you do that with diffuse liver mets? How do you make that?
That's for diffuse liver disease. not oligometastatic. For oligometastatic liver disease, depends on what your institution is. Some people want to IR those, do whatever, but I would like to say that I think SBRT is a far better approach to manage the liver than any IR intervention can do. We can actually see the whole target, treat the whole target, and it doesn't require an invasive approach. So, and I'm not a GI radiation oncologist, but I can just kind of compare the two and tell.
Great, thank you. So we are now second line therapy. Prior to first line, we had an ESR1 mutation and a PIK3CA mutation. Is anybody on the panel, could somebody speak to the biology of ESR1 mutations versus PIK3CA mutations when they develop, whether we expect them to go away over time? If anyone could give us a little information on that.
Matt and I are both curious to see what each other thinks, because I would have said prior to San Antonio this past year that PI3 kinase mutation, is associated with endocrine resistance. That pathway is an important, mediator of resistance, and so I would have thought that that would be your go-to target when you have mutations in both pathways. That said, there was an EMERALD update subset analysis at San Antonio that looked at the PIK3CA mutant subset in EMERALD, and their hazard ratio was as favorable as the intent to treat population, suggesting that targeting the ESR1 is laudable, even in the presence of PIK3CA. So I was surprised by that. Now it's retrospective subset analysis, exploratory endpoint, all the caveats, but there was a signal there. It's unambiguous. It's really interesting, but it puts it back on the table for me. I think a balanced discussion with a patient like this would be probably the right thing to do ethically, but I'm really curious to see what Matt thinks in terms of which is the driver. Or both, or synergistic.
Yeah, well, PIK3CA, unlike ESR1 mutations, are present at diagnosis, and so it's part of the sort of etiology of the disease. All our sequencing studies showed something, I think, similar to what you're saying, is PIK3CA and ER-positive, HER2-negative disease associated with actually a better prognosis. Actually, it was a paper I published with Jose Bazalga about 10 years ago, so that's not a new finding. In the presence of HER2-positive disease, it's the opposite. So if you have a PIK3CA mutant HER2-positive, ER-positive, they do worse. So it's a little bit dependent on the context. I was curious about whether there was any evidence of a PTEN AKT loss, as well as the PIK3CA, because of the recent data on capivasertib, and what are people doing about that drug in this kind of setting, as opposed to alpelisib?
Yeah, I'm preferentially using capivasertib in conjunction with fulvestrant. With alpelisib, some of the challenges were the hyperglycemia in particular, and then also the rash. And when we look at the Capitello 291 data, it does overall have, at least from what we can see in that data, much lower rates of hyperglycemia. Back when we were using alpelisib, more frequently, really substantial issues with hyperglycemia, patients ending up hospitalized because of blood sugars, in the 600s,
500s, yes,
DK.
yes.
Right.
But you don't see that so much with capivasertib. So the general feeling it's a safer drug, less skin rash, and doesn't look any less effective. You can at least say that from indirect evidence.
That's correct, from what we can see of the Capitello 291 data, as well as the Factian phase 2 data.
Yep.
So I'm going to ask you all the med-oncs to go down the line and say what would be the treatment in this case that we would use. I'll just remind you of her that she has no past medical history, so no obesity, no diabetes, and a good performance status. Heather, you can start. Dr. MacArthur.
I guess my other two questions and follow-up to the rest of the panel is frequency of co-mutations and frequency of loss of actionable mutations after further systemic therapy. So just to throw that out there. I would probably use elacestrant in this case with an ESR1 mutation, very well tolerated, single agent, oral therapy. It's easy to give and don't have any of the diabetes and other complications of the alpelisib type regimens.
Yeah, I agree with the statement that before that it really is a discussion with the patient as to the side effect profiles of both drugs. But if the patient said, I don't have a preference, I would give elacestrant for the reasons that were just said.
I would as well. In the subset analysis of EMERALD, for patients who had an ESR1 mutation and who had had at least 12 months of CDK4/6. The median PFS with elacestrant in those who had a PIK3CA mutation as well was 5.45 months. If you look at Capitello 291 and you look at those, well, the subset analysis in Capitello 291 was not confined to the 40% who had a mutation. So we're looking across the board at everybody. But in those with liver mets and in those with prior CDK4/6, it was also about in the 5.5 month range median PFS. So it's about the same. So I would go with the least toxicity at this time.
I think either elacestrant or fulvestrant Cap-B would be reasonable. I would probably favor elacestrant because of toxicity, but I would say I would also repeat
NGS before making the final decision in the real world.
OS, the one's right. I think Cap-B data is a little worth estimating. I'd say the Cap-B data is still a bit immature, and some of the phase 2 data suggests the possibility that there might be some prolonged responders that could drive open smiles. So let's just wait and see where that data goes. It's never a bad idea to repeat the NGS, multi-tailor engine disease, and opens involving the undetectable before. But I think elacestrant sounds to be going followed by Cap-B, I guess, for the Western certainly again. We don't know what the efficacy is of monotherapy is at this point.
As this is cumulative treatment, I always think exclusively about the ability to get dex. That is see the biodynamic toxicity. And I think elacestrant wins on that front in this case. And so I'd use elacestrant for that reason. That's a myosin and some nausea with elacestrant that can be problematic. You do have to get out further with co-medication. So, but other than that's probably an honest opinion.
In this case, there are 3 approved indications that we could consider. For the reasons that I mentioned earlier, I would favor alpelisib. And so completely agree that it would be a balanced discussion between elacestrant as compared to Comhiba with fulvestrant. And I actually would feel comfortable with either in this setting. However, given the sense that we've had from this patient's decision making and also what we've learned of her so far, that she wishes to focus on quality and is interested in treatments with manageable side effects, it will undoubtedly be more facile to take elacestrant, to not have to come in for intramuscular injections as well. And so I may slightly lean towards elacestrant in this case.
Wonderful. Any other thoughts about this case before we move on to case 2?
Questions I'm not sure were answered, which were I know they did on the spot. So frequency of co-mutations in patients who progress after, let's say, first one, this is a unique case for a variety of reasons, but let's say a patient is on 2 years CDK. What is the frequency? Because I have struggled to understand the number for co-mutation statuses for these PI3K and ESR1, and then loss of actionable mutation status in response to therapeutic pressure.
But definitely in the hand, what the ESR1 mutations. And again, the truism is that sometimes that's due to ESR1 translocation. The P published on last year. Up down, I'm on 5 or 6%, but the generation setting has been lying in binding domain. The transactivation domain is pulled from another chromosome. There is a study that I developed the Borlin because these ESR1 translocation, they have very underminable red kinase, which is an estrogen receptor driven kinase. So we're repurposing bit-methinin, calcetinin. Sorry, well, this drugs and keep me sound the same, but calcetinin in some sweeping common match. So I think we're chasing our tails all the time in these patients. So your questions are excellent, and the other thing that can happen, and this is actually another paper did Isaiah before he died, with the marriage done treating her more. You could have 5 or 6 different ESR1 mutations, all PIK3CA mutations, do those bits. I mean, it's completely insane. Right. So, it's the old way of, well, I'll disappear, but new ones are mounting up with resistance, the ones who are driving into them.
Jean, just for a pragmatic conversation, you said you've currently been pursuing saying for the year right there in.
There wasn't saying all you were to see and say that's
In further mutations in ESR1, a response to therapy and registers with base sequence.
oh, when you say sequence after DNA sequence, you're talking about drug sequencing. I got is I think a little bit is to do with what the indications are and whether there's any respect from one another trying to do all yes, but there was this some coming kind of presence mutation to maintain forward. I would only give capping the cert in this setting to give yes I guess in avenues or mutation or then there the real frequencies with the demand whereas the RNA from the thing that she will respond to the others because it's obviously talking about that and
If the patient got 6 months on their CDK4/6 inhibitor, is that changing people's opinion?
that's very worse one thing. It means that them further healing is some even primary diagnostic breast cancer, some will look like that. We can put those from the neoadjuvant clinical studies. The KCC7 is just flat. The clinical is not all about the signal was added, had no effect in KCC7. They did that had sort of Harvey plus other causes of dysfunction when found on mutation. So there are some tumors that are masquerading as the old Austin, but they have David Ormus Ostis toy because they had this program tumors check. Certainly, how was skin on does that check sense? So the problem is with the others of breast cancer, they don't really do the statistically tested as we mean and pull out and use something. And that's because you don't lost the breast cancer, there's no indication for sequencing primary breast. So all chasing and telling those that disease of that has to change. Right? On muddy legend, there are patients in new imagine of capping the cert can be off. Would that ever happen? That mean happen in patients in genetically and she was supposed to respond and indeed had to assess whether measures were happening and where Mel is not. So I think there's a big problem in breast cancer, but also just in the medical cancer markers. All lung cancer in NGS are due to mutations. L'Oreal fusion or whatever. It doesn't happen in breast cancer. Need primary. But that's where they start making an impact. Because the only time you cure patients with also breast cancer is the first outpatient when you get it. Once they relapse, it's all fake. Fits in very rare cases. We all have a few of those, right? But no, that's what I'm saying. I'm a bit frustration actually.
The story of these resistance mutations continues to evolve in breast cancer as it has for other solid tumors. Striking examples of that include HER2 kinase mutations, where you can get second site mutations, including the classical gatekeeper mutation, analogous to that in EGFR receptor of non-small cell lung cancer, after selection pressure on EGFR kinase inhibitors. So that's very clearly a cause of resistance to HER2 targeting TKIs. But there was a paper from Alan Ashworth at BRCA2 mutant prostate cancer a couple of years ago. He first reported those reversive mutations where you get a mutation in BRCA genes that leads to a premature stop codon. So you lose function while the remainder of the protein is not synthesized. And the tumor can simply excise the original mutation that yielded the premature stop codon, restoring an in-frame intact BRCA protein. When I read that paper from Alan, I was ready to quit college. I mean, like, how could a tumor possibly end up 3 billion beta pairs to just excise that one? I mean, I wouldn't have even thought about myself. I mean, it's brilliant. But his latest paper in BRCA2 mutant prostate cancer, they showed a case report of a patient under selection pressure from one carbon inhibitor had dozens of reverted BRCA2 continuously restoring in the same patient. So it's like George Sledge always says, one dope tumor is smarter than 10 oncology.